Hi, everyone. Thanks so much for tuning in. Today, we are going to be talking about management of esophagus, gastric, and G-junction cancers. Obviously, lots of things we could talk about with all the new studies and presentations coming out. But I wanted to focus on two, I think, timely topics. One is the Matterhorn study, which was just presented and published back in June of this year. And the second is sort of the treatment paradigm of non-operative management for esophagogastric cancers. So today we are so lucky to be joined by two world experts, two GI medical oncologists who I ask all the time when I have questions regarding systemic therapy. So the first is Dr. Sam Klempner from MGH. He was actually the discussant for Matterhorn at ASCO this year. So thanks, Sam, so much for coming.
Yeah, no, thanks for having me.
And the second is someone I work with very closely, Dr. Tim Brown. He is here at UT Southwestern in Dallas, Texas. Okay, so let's jump right in. I am just going to maybe briefly go over the Matterhorn study. Um, all right, can you guys see the slides?
Yep.
Yes.
Okay, so this is from Sam's presentation here last month, or I guess this month. So Matterhorn was a study in gastric and G-junction adenocarcinomas, and the question was whether or not adding durvalumab improved outcomes as compared to peri-op FLOT. So patients in the control arm got the standard of care with peri-op FLOT before and after surgery, and then in the experimental arm, they got the addition of durvalumab both before surgery and after surgery with FLOT, and then a year after. The primary endpoint was event-free survival, which included a composite endpoint of distant progression, relapse, or death. And then secondary endpoints are overall survival and pathologic complete response. So I love that this was presented. Sam did an awesome job discussing it, then published the same day. So this was a positive study with improvement in EFS from 59 to 67% at 2 years. And then OS I don't have here, but was trending towards positive, but at the time of presentation was not yet mature. So yeah, so I guess I'll just start by saying, this was obviously a positive trial. But for me, as an outside observer, I guess it wasn't like a total slam dunk. EFS was positive by 8%, but OS we're kind of still waiting. So I guess just to start, and Sam talked a little bit about this in the discussion. Just your overall thoughts on the study. Would you offer this deflot regimen to all patients, maybe regardless of CPS, while still awaiting OS outcomes? So Sam, why don't you start?
Sure. So I think yes, my short answer is yes, but I will explain. So event-free survival is essentially in a maybe more patient-centric way, being alive essentially without recurrence for the most part. I mean, there are other things that can define events, as you said, but event-free survival is somewhat in the eye of the beholder, whether you feel that that is a practice-changing endpoint in the absence of known overall survival data. I think we, of course, want to delay recurrences and cure more patients. That is the ultimate goal. And we don't have the overall survival data. But I think in talking to patients and in thinking about this myself, if I were a patient, if a therapy were to improve or delay the time to recurrence and preserve that time for me, I would consider that something that I would want to be exposed to. Of course, it's on balance with the toxicity of the added intervention and things and many other factors, cost, etc. But to me, the totality of the trial and the 8% improvement are clinically meaningful and would change my practice. So short answer, yes.
Tim?
Yeah, I completely agree. This was a positive study. It met its endpoint. EFS perhaps not as rigorous as OS. However, having to take care of patients with recurrent gastric cancer, I know it's a devastating disease, and anything you can do to delay the time to recurrence, in my opinion, is meaningful, and I would imagine most patients would agree as well.
Okay. And then like regardless of CPS or Sam, I know I asked a little bit on the side of, this compared to checkmate and the sort of the difference with regards to response based on PD-L1 expression.
Yeah, it's a good question, and I think um, it's two parts. One is biology. I do think that there is a relationship between PD-L1 expression and benefit from checkpoint inhibitors, and we've seen that in a large body of stage 4 trials. And there was a relationship that held up in Checkmate 577 with nivolumab monotherapy. I think um, for partly for reasons of small subgroups, there's only 10% of patients in Matterhorn that were PD-L1 negative. So there's a small subgroup of patients with a very wide confidence interval. I think the biology is real, but at the same time, looking at the subgroups in Matterhorn, I do think that even the PD-L1 negative patients, that subgroup hazard ratio is still in line with the overall effect and something that my own practice clinically would be to offer independent of PD-L1 status. Although I do think that when we see OS data by strata, there may be some differential magnitude of benefit as we've seen in other studies, but that remains to be known.
Okay. And then this trial had G junction and gastric cancers. Are you taking this up the GI tract to esophagus cancers as well? And related to that, we'll start with there. Tim, you can start with that.
Yeah, it's a good question. I think what it's going to come down to is how the NCCN sees this and the people who vote on the NCCN. I think from a purist standpoint, this should not be used for esophageal cancer. There were no patients with esophageal cancer on Matterhorn. That being said, we know FLOT is active in esophageal cancer based off of ESOPEC. We know that checkpoint inhibitors have a role in esophageal cancer. It's hard to construct a strong argument that this should not be used. I part of me almost wants the NCCN to not endorse it so that we could actually do the trial because once it's endorsed, there's no more equipoise and it's going to be very hard to do the trial. But the other part of me too thinks I want my patients to do as well as possible. If it does get endorsed, if you can get payers on board with it, it's going to be hard to make an argument against it.
Yeah, I would say, maybe a couple clinical points. I think it's often hard to distinguish a Siewert-1 tumor from a true esophageal adenocarcinoma based on endoscopy and imaging. And I think it's actually quite a small proportion of patients that have true esophageal adenocarcinomas that don't involve the junction. And biologically, I think they're very, very similar to GE junction cancers, lower esophageal adenocarcinomas. And so my own practice is probably I would extend this more proximally, but I totally understand and agree with Tim. From a purist standpoint, this is not a population that was studied. So in fairness, we don't have specific data.
Okay. And this is just like a practical question, but I know when ESOPEC came out, there's a question of like, can patients tolerate FLOT? What about dose reducing FLOT? I guess I haven't heard as much of that discussion with the durvalumab, like with the exception, obviously, of patients who can't get immunotherapy because they have severe autoimmune conditions. But other than that, are there questions about tolerability of the drug? And you mentioned a little bit about toxicity.
Yeah, I don't think durvalumab adds a whole lot in terms of toxicity aside from sort of the typical immune-related adverse events that we know how to watch out for. The bigger question is when you meet these patients is, are they surgical candidates? And if so, are they also FLOT candidates? The durvalumab, I think, doesn't add a huge layer of complexity to the administration of these perioperative therapies.
Okay.
Yeah, I agree. I think, in practice, we are pretty liberal with dose reductions for FLOT. In a global trial like Matterhorn, I think you can see that the neoadjuvant component is something that most people get through, like more than 90% of people. So we're getting better at giving FLOT and other triplets. I know my own personal practice is it's very common that we wind up reducing the oxaliplatin or the docetaxel or both during the course of therapy. I think the how much does the triplet add is an an unknown question. Although if you back of the envelope compare doublet periop like cis-5FU pembro versus FLOT pembro, for example, or FLOT durvalumab, off the cuff cross trial comparisons, the triplets do look numerically better for both the control and experimental. So I think triplets are here to stay, but definitely, take some experience to get used to adjusting FLOT. But I think in experienced hands like Tim or myself or many others, I think we can get a decent amount of FLOT into most patients.
Got it. Okay. Okay. The next question, you talked about this a little bit in the discussion, but these patients are getting obviously neoadjuvant durvalumab, peri-op, post-op, but then also a year extended. I guess, maybe we don't have that exact data yet, but will there be future studies looking at how much that adjuvant component you think adds? Because I think there was another study, the attraction study, where it was, I think that, correct me if I'm wrong, it was just adjuvant and maybe it was not positive. So maybe just comment on that. If we can take away that year, then obviously that's a lot less treatment burden and cost and whatnot. Either one.
Yeah, I can start, sure. Yeah, this whole idea of contribution of phase, how much does the neoadjuvant component drive the effect? How much does the adjuvant add? How much does the extended adjuvant or whatever you want to call that additional 10 months of durvalumab really add? Matterhorn is not designed to answer those questions, so it's not totally fair, but I hope that they will actually give us some clues as to, how the people who never got adjuvant FLOT did, or how the people who only got some doses. So we may still learn a lot. But yeah, I think it does raise a lot of important issues like cost, and especially in resource constrained areas of the world. And it very reasonable to think about a large study where you said, okay, let's do durvalumab plus FLOT and versus durvalumab plus FLOT without the 10 months. Like that would be an academically interesting, clean study to answer that question, but it may not ever happen.
Kim?
Yeah, yeah, I agree. I mean, the other side of that too is it's a lot of time commitment too, from even from a patient standpoint and from an infusion center standpoint. And so understanding what the additional 10 months of durvalumab is adding to the, overall treatment, I think is going to be important. It's probably data that we're going to have to collect from the real world. It's going to take many years to really understand that.
Yeah, I agree. I think until we have data like that, it's hard to say that, a patient in front of me, I'm going to say, oh, you don't need this because we just don't know yet. It's kind of like the nivolumab from 577, go to 3 months or 6 months or 12 months. Melanoma, I think is starting to generate some data about durations of immunotherapy because they can do these kind of nuanced trials maybe a little bit better with so many patients getting checkpoint. But yeah, I think until we have that data, we're going to be giving it as it was done in the Matterhorn.
Okay. Last question on this, obviously, with ESOPEC, and then, ESOPEC really changed our practice here right after the presentation. And then, this trial, we're primarily now using cross for patients, for squamous cell carcinoma patients. And then also, if we find a patient that is not able to get FLOT, for whatever reason, they have other, like organ, end organ disease. And before, I think we were just a potential benefit of cross was that post-op they could get nivolumab, but now there's this study with getting immunotherapy with a FLOT. So maybe, are you guys still using cross in Boston for any of your patients, or has this not really used anymore?
I'd say exceedingly rare where we would use the traditional cross approach. I think this highlights, one of the big issues, which is the importance of multi-D discussions of these patients. I think one of the areas where we do think about incorporating radiation is when the surgeons tell us that they're very worried about ability to get an R0 resection, whether it's a tumoral feature or an anatomic feature of the tumor. So it is still important to have radiation on the team and available. But I think for a traditional operable patient, very, very rare that we would be thinking about cross. And in fact, if in patients who are not FLOT candidates for medical reasons, I will still lean towards like 5-FU and oxaliplatin, like more of a FOLFOX type approach if it's possible, if there's not a medical contraindication. And then, as Tim alluded to earlier, if someone is not a surgical candidate, then obviously the paradigms are a little bit different because they don't really fall into the Matterhorn or Esopec world anymore if they're not operable.
Yeah, and Tim, I think you can comment our practices, I think, are pretty similar, looking at sort of a case by case.
Yeah, yeah, I agree. It's flawed unless there's a compelling reason not to. I think the one major exception is the patients with squamous cell carcinomas, where you can expect a very high complete response rates. But in general, for all comers, we're looking more towards the perioperative flot. I've also done, total neoadjuvant FOLFOX, or even the PET adapted from the CALGB study kind of approach in someone who I need to induce more of a response for.
Yeah, I think one area that we have sometimes interesting multi-D academic debates is this like T2N0 clinical subgroup, which
Yeah.
very, very rare in my experience that we actually find people who are T2N0. And I think they were like, 4% of ESOPEC, it's a really tiny little subgroup.
Even small and cross too. I think a little bit,
Yeah.
but still a small proportion.
But I think, if we had testing that was good enough to tell us that it was really a T2N0 and there wasn't an occult node, I do think that those are patients where a local regional strategy might be all that you need. The problem is like we just can't really define them clinically before we start. So I think our practice is still to give those patients, multi-agent systemic chemotherapy like FLOT, although I admit that if someone is truly, truly a T2N0, we may be over-treating them.
Yeah.
Yeah, so often you go in thinking somebody is T2 and then you operate on them or you do more staging EUS or something like that, and you find it's T3 or even worse, T4.
Yep,
So it's very hard to have a lot of confidence in a T2 in zero.
Awesome.
totally,
Okay.
totally.
Okay, so summarizing Matterhorn, this is a positive study. I think, where you guys are recommending this regimen to patients who qualify, the criteria based on the study, plus minus extrapolating to esophagus, but leaning towards potentially doing that, given similar biology. I think we do want to be on the lookout for mature data on OS and then perhaps additional data on subgroups with regards to the adjuvant component. Okay, perfect. Okay, let's switch to our second topic, which is organ preservation. So, several trials on this, but just wanted to summarize one of the larger ones. So this was a SANO trial. This was presented and then more recently published. This was done in Europe as a phase 3 cluster randomized trial, including 12 centers. And these were patients who got only preoperative chemoradiation of 41.4 Gray. So just a cross regimen, no additional chemotherapy. And then if they had a clinical complete response, they were randomized to either immediate surgery or active surveillance with periodic responses. And then if they had recurrence, obviously a local recurrence, they had surgery. If distant, then they had systemic treatment. So this was a non-inferiority study with a 2-year overall survival as a primary endpoint, and it was positive, meaning that active surveillance was non-inferior towards surgery, and quality of life was improved at 6 and 9 months. I think when this study came out, well, first, when the initial results came out, there was a question of how much is adenocarcinoma, how much is squamous cell carcinoma, but they were both represented in the actual cohort. And then, as someone who treats all GI cancers, where we're definitely seeing a trend to non-operative management. This is just OS by their modified intention to treat, which include crossover and then intention to treat. I definitely saw some parallels with rectal cancer with regards to organ preservation, and this is definitely something that I think patients are interested in. It's a little bit different than rectal cancer. even though there are a lot of parallels in that the proportion of people who have sustained recurrence is lower. And then also, I think distant Mets are such a major competing risk. But I think from, you know, this being a potential possibility for patients, I think this is potentially a start, but they're only getting 41.4 gray, which is kind of low, and they're also not getting any induction chemotherapy either. And obviously, distant Mets are such a risk in this disease site. But that being said, I think, talking to colleagues here and then around the world, I think reception and sort of taking this into practice has been mixed, particularly with regards to other studies like Matterhorn and others that have come down the line and sort of how to balance um, the different treatment options and patient desires for organ preservation. So maybe I'll start with Tim first on your kind of thoughts on this study and sort of the direction of organ preservation.
Yeah, thank you. So this is an interesting study that unfortunately is a little bit less relevant today than it would have been maybe a year or two ago. I think the important thing to consider when you're interpreting the data for this study is that these are patients who otherwise would have been, operative candidates. These are not sort of the patients who are non-operable either due to medical or surgical comorbidities. Because of that, I think the strategy and the surgical risk is a little bit different than who we might in the present day put through a cross regimen and then do a salvage esophagectomy, for example. So these are patients who got the typical cross chemoradiation and then had a complete response, which, as we know, with cross is going to be somewhere between about 10 to 20%, and then had very, very close and intense follow-up out to 5 years. And I think one of the remarkable take homes is you don't lose anything in terms of your overall survival with an upfront resection versus waiting for time of recurrence. And it seems like the pattern for distant recurrences is also the same. So if you truly have somebody who is a surgical candidate upfront who says for whatever reason they don't want to go through surgery, I think this strategy may apply to them, understanding that the surveillance protocol is very, very intense.
Got it. What about you, Sam? What are your thoughts?
Yeah, I think Tim covered a lot of it. I mean, I I also thought the surgeon who wrote the editorial for this paper was really, really excellent editorial. And I've read that one a few times to help interpret the data. But I agree. I think it's a decreasing patient population that are getting neoadjuvant chemoradiation, so the relevance is a little bit less, and we don't know if this will hold up in the world of FLOT yet. I thought that they probably defined an adequate surveillance strategy, and as Tim said, it's very intensive, but they did pick up a lot of the local recurrences without distant recurrences, and many of those patients, I don't remember the percentages, were able to undergo salvage operations. So I think that they may have defined a surveillance strategy that could be used to incorporate into other non-operative organ sparing approaches and designs. I think that, as you said, patients real esophagectomies and gastrectomy is a huge operation, and it's a life-changing operation, no matter what. Even people who do the best and get back to normal, their life is still different. And so I think we all totally understand that we want to get there for patients. But as you said, the occult metastatic disease and this tumor type and the late presentations are somewhat barriers to doing that. So we have to be careful and thoughtful. And I think that still is going to need systemic therapy before I would put someone down a path towards this. We offer it for squames, I think, where
Mhm.
it's a different biology, local problem, a lot of more local invasion and before
More
distance
radio
spread.
responsive too.
Yeah, more radio responsive. So I think, for squames, we are kind of doing this. For adenocarcinomas, I think we've been relatively hesitant. Um, Sometimes there's that like 86-year-old patient who's otherwise very healthy, but they don't want an operation, and you're a little worried about an operation. And so we will think about sort of intensive surveillance.
Yeah, I think for us, like one of the I agree. I don't think like a perfectly healthy patient, you're at this point you would offer just the cross regimen up front. But in the chance a patient gets that and has a complete response, then I think and is willing to follow up, um, then I think this study has made us more comfortable either sort of doing a second surveillance to ensure a complete response and maybe waiting on surgery if that's what the patient wants. Um,
Yeah, very important, a very important topic to continue to study for sure.
and Sam, you had mentioned that there were some trials that looked kind of promising, using targeted therapies, increasing the pathologic complete response with just systemic therapy.
Oh yeah, definitely. I mean, I think um, if we can approximate the local responses and regional responses with systemic therapy that are achieved with radiation, then the question becomes, how much does the radiation be required? And so one of the or some of the subgroups where we can do that clearly is people like MSI high and some of the HER2 populations where we know from some phase 2 data for MSI that those patients do exceptionally well in neoadjuvant with just IO and maybe probably chemo IO. So now I think we have to expand that paradigm to other biomarkers. And HER2 is probably the next one. There was a couple small trials that have reported like path CR rates in the like 35 to 50% range. And that is better or at least comparable to anything you can get with radiation-based combinations in adenocarcinomas. So if that holds out, then I think there is a path potentially to non-operative management in those patients even without radiation.
Yeah, I think that, radiation is so much of it is dependent on obviously the histology, but also tumor size too. So like, if we have a patient with a small tumor, even an adenocarcinoma, then I think there is a good chance that the radiation can be curative. But I agree. I mean, with these larger tumors, adenos, it's probably unlikely to have a complete response. And I also agree, yeah, I think it's hard with knowing how these patients recur at this point to, not offer any systemic therapy, kind of like, in other disease sites like pancreas cancer or something where, we know that systemic is pretty important.
Yeah.
Any other thoughts on organ preservation?
I would only add that at ASCO, they also showed the recurrence patterns from ESOPEC.
Yes.
And, as expected, the more active systemic FLOT versus the less systemically active cross approach, the FLOT did clearly reduce distant recurrences, which, as you said, is really the problem that kills people here. So I think it's just another point on the like you really need active systemic therapy kind of column.
Yeah.
Yeah, I
Um,
totally agree with that. I guess I did have one question. As we're seeing sort of our effective agents move from the metastatic setting to the curative intent setting, for example, with durvalumab now being in the perioperative setting or potentially with HER2 targeted agents, how are you thinking through what you're doing for these patients at time of recurrence or at time of metastatic presentation?
Oh man, I thought we talked about not asking any hard questions. No, very, very practical and an important point. I think with mature data from Matterhorn, it will also be interesting to look at the post-progression or post-EFS event IO use between the two arms and see how people are actually using it in the real world. I think in fairness, we just don't have data. So like even when Checkmate 577 came out, we were also kind of struggling with the same paradigm. If someone was on adjuvant Nivo and then they completed it and then 6 months later they recurred with metastatic disease, like do you give them checkpoint inhibitor? I think in absence of data, we kind of pick 6 or 12 months as the arbitrary point and also look at the PDL1 status for the patient, where in the metastatic setting, we know there's a pretty clear relationship. So And then there's a little bit of like, I don't want to say gamesmanship, but getting patients, to preserve the most options for the patient, sometimes giving them standard systemic might open doors for second line trials, etc. But to answer your question shortly, I think we kind of picked minimum of 6 months before we felt like there was going to be a real benefit to adding back the IO, but that's not really based on any specific data.
Yeah, it's a super challenging setting to be in, and we definitely need more data, and definitely something that we're going to have to deal with in the upper GI space as we begin to move all of our effective targeted agents into these curative intent settings, understanding that we're not curing everybody anyways.
Yeah, I think that's a great, maybe that's something we can all do as a real world project because, that or some multi-institutional retrospective in a couple of years because it is very relevant and important question to see like what people actually do and whether those patients do worse or better or equal. We don't know.
Awesome. This was really, really great. I think, as I listened to the discussion, I think there have been like so many advancements with regards to systemic therapy. And I hope that in radiation oncology, we can also do studies that, um, better sort of pinpoint where we can fit in so that it's, obviously it needs to be on an individualized basis, but ideally backed with data, better data versus sort of anecdotes and data that is maybe less relevant with new studies. But anyway, this was really helpful. Thank you guys for doing this. Sam, have a great time at ESMO GI. Tim, we're still stuck in very hot Dallas. Awesome.
Well, it's gonna set off some fireworks for the holiday, though.
Oh, jealous. That's awesome. I love the 4th of July.
Awesome. Thank you so much, guys.
I'll see you.
Of course.
All right, I'm gonna